There is a phrase that describes the current standard of care for psychiatric medication prescribing, and it is not flattering. Trial and error. A patient presents with depression. A physician prescribes an SSRI. The patient takes it for 6 to 8 weeks. It doesn't work or produces intolerable side effects. A different SSRI is tried. This process repeats, sometimes for years, until something works or the patient gives up. This is not a description of a failure mode. This is the intended protocol. And it is, in the context of what we now know about pharmacogenomics, an almost entirely unnecessary ordeal. The CYP2D6 enzyme, encoded by the CYP2D6 gene, metabolizes roughly 25% of commonly prescribed drugs, including most antidepressants, opioids, and antipsychotics. Individuals inherit variants of this gene that place them into functionally distinct metabolizer categories: poor metabolizers who accumulate dangerously high drug concentrations, intermediate metabolizers, normal metabolizers, and ultra-rapid metabolizers who clear drugs so quickly that standard doses never reach therapeutic levels. Every one of these categories produces a different clinical outcome from the same prescription. This information is available. The genetic testing exists and is relatively inexpensive. Companies like GeneSight and Genomind have commercialized comprehensive psychiatric pharmacogenomic testing panels that identify relevant variants across multiple drug metabolizing pathways and transporter genes. The data from these tests could, in principle, allow a psychiatrist to select both the right drug and the right dose on the first prescription with dramatically higher probability of success. The technology is not the limiting factor. What is limiting adoption is a combination of insurance coverage gaps and physician education deficits that are, in a healthcare system ostensibly committed to evidence-based medicine, genuinely difficult to excuse. Adverse drug reactions, many of them pharmacogenomically predictable, are among the leading causes of hospitalization and, by some estimates, the fourth leading cause of death in the United States. This is not a niche problem with an exotic solution. It is a massive, measurable harm with a currently available partial remedy. The expansion of pharmacogenomics into cardiology, where CYP2C19 variants determine whether patients adequately metabolize clopidogrel, the antiplatelet drug given after cardiac stents, is particularly urgent. A patient who is a poor CYP2C19 metabolizer taking clopidogrel after a stent may be receiving essentially no therapeutic benefit, and the consequence of that is stent thrombosis and a second heart attack. The FDA has a black box warning on clopidogrel regarding this interaction. The testing that would identify at-risk patients is available. Many physicians still do not order it. The prediction of universal PGX testing before first prescription is inevitable once insurance barriers are resolved and medical education catches up. The only question is how many preventable adverse drug reactions occur in the interim.